All right. So welcome everybody. Welcome to our free workshop. We're going to be talking about important things you should know when you're first diagnosed. And this is all very personal for us because we made this whole workshop because we remember, back when we were diagnosed and some of the things that we wish we would have been told. So this is for you. So I hope you enjoy it. I'm going to go ahead and screen share. Ooh, sorry. Okay, can we see all that? Can you see it okay?
Yeah.
Okay.
Yeah, I can see it.
Is this in the way? Or,
Uh,
or you're seeing everything okay?
yeah, no, I see everything. Yeah,
Okay.
it's good.
Okay, so I'm Ashley and Rebecca is also here. We are the Crohn's and Colitis dietitians, and we have a team of, there's 5 of us, and we do free workshops. We're starting to do it every month. And we help people both one-on-one, and we also have a group program that we work with people in. So we're going to talk about top things you need to know if you're new to IBD. So Rebecca, you can start us off here.
Yeah, so, I don't know about you guys, but actually, I'm sure, well, it depends if you are just coming off of propofol or maybe, you remember your doctor telling you, hey, you have Crohn's disease or you have ulcerative colitis, or, we have to take some biopsies. It looks like you may have microscopic colitis. So, I don't know if maybe some of you have experienced not really knowing what that meant, like just kind of, what in the world does this diagnosis mean? Um, and, that I know that today we're really going to take a deeper dive into what it actually means so that you guys, leave here having a way better understanding of what it is than when you first came on. So a little bit about IBD. So inflammatory bowel disease, there are different types. So we know that there's Crohn's disease, which, the thing about Crohn's is a lot of the time we hear that, the most common spot for Crohn's disease or where those ulcers are found are usually found in the ileum. But the reality is that Crohn's disease can occur anywhere from the mouth to the anus. And so, usually with Crohn's disease, it kind of skips through. And so as you see on the left with Crohn's disease, it's kind of, it skips from the small intestine. You see it kind of skipping around in the large intestine. So that's a little bit of the presentation of Crohn's disease. And so what we do know though is that with Crohn's disease, symptoms of Crohn's disease can actually be quite similar to ulcerative colitis, but we know that they can also be a little different in the sense of stricturing, narrowing. There could be partial or full blockages. So while Crohn's and UC can be very similar, they're also very different. Ulcerative colitis, so this is strictly in the colon, and so colitis means inflammatory colon, and ulcer, right? Ulcerative is ulcers. And so when we see here the way UC presents itself, we see that, in this situation, it's really affecting that left side of UC. And so a lot of the times, you'll hear your doctor say maybe left-sided, maybe you'll hear extensive or pancolitis or proctitis or proctosigmoiditis. And so all these different terms are just really representing the location of the ulcers. And so that's what those terms mean. And usually Ashley and I, what we like to do when we work with our patients is really focus in on education. So, like if I have a patient and they tell me, hey, I've been diagnosed with pancolitis, like what does that mean? So pan means all over, right? And so that's what pancolitis is versus proctitis, where it's only reserved to the rectum and that specific area. And then we look into microscopic colitis. So we see here the thing about microscopic colitis, and it's interesting because Ashley and us and her team, we were talking about this, that celiac disease tends to be pretty common with microscopic colitis, and microscopic colitis can be confused with irritable bowel syndrome because the symptoms overlap each other, which is quite fascinating. And so there are two major types of microscopic colitis. So we have collagenous and we have lymphocytic. And so these two different types of microscopic colitis, they have to be seen under a microscope. So even more important to ask your doctor, hey, did you do biopsies, right? Because we can't just look inside the intestines. So the next question is, what is a flare, right? And so I know, I just to kind of share with you all, I have ulcerative colitis. I've been symptomatic for the past 6 or 7 years, recently diagnosed about a year ago. So, and I'm sure a lot of us can probably relate to kind of being turned away by our symptoms, like, oh, you're young, you look healthy, nothing's going on with you, right? But we know that we felt something, right? We know that something is off. And so this kind of leads us to looking into a flare and what is it? So you can have a symptom of a flare, or you can have a flare that's inflammatory. So it could be symptomatic, or it can also be inflammatory. And so a flare specifically is when you have symptoms and that inflammation becomes active. And so that's the difference between a flare up and symptoms. So you can be symptomatic, but when there's no inflammation present, it's not a true flare. Flare is like the immune system is like, it's like going, right? It's all in, it's very hyperactive. And so symptoms can include abdominal pain with or without nausea, vomiting, diarrhea. We see weight loss. And weight loss, it's an interesting one because, for instance, we know some of us could be very active, or we're runners, or we're swimmers. And so we think, oh, okay. I mean, I know at least for myself, at the time I was swimming, doing yoga, running, and, I thought, oh, okay, I'm losing some weight. Maybe this is because of my exercise routine. But when you start really losing weight and you're like, wait a minute, like something doesn't feel right. Like now this is like happening really fast. That's a sign that your body is fighting off something, and that's an inflammatory response. So it's hypermetabolic, and that's what's causing this weight loss. So it's weight loss from the inflammation. And then fever can definitely present itself. Bleeding, of course, especially when your IBD is affected in the colon. Urgency, tenesmus, fistulas, blockages, lack of appetite, which I know a lot of us can relate to. Joint pain, perianal issues, especially for our Crohn's patients, and bloody stools, especially for our UC patients. Flare-ups can last anywhere from several weeks to months. So, again, that's why continue being an advocate for yourself, getting that diagnosis. If your meds aren't working, getting a change in your medications, because you never want to let inflammation just sit and roam around in your body. They can occur when a patient has been in remission for months or even years. And lab tests, stool tests, and colonoscopies can all help detect inflammation. So there are ways to look at that. So then we look at symptoms versus inflammation. And I think that this is something really important to remember, because it's important to remind yourself that if you ever feel symptomatic, to remind yourself, okay, I'm not going into a flare. This can simply mean that something didn't agree with me, or, it could just be my IBD showing up in a different place or causing some symptoms. But again, it doesn't mean that I'm inflamed and I'm hypermetabolic and I'm going to lose weight again. So it's important that we don't start thinking about those things. And so when a food triggers symptoms, it doesn't mean it caused your IBD. It doesn't mean it caused your flare. And it doesn't mean that it's causing harm. And that's kind of what we're trying to say here. But this also doesn't mean that nutrition and food that we eat don't matter or play a role. So I know something common that GI docs will say is, you can eat whatever you want, take these pills and you're good to go. And so it's important to remember that, nutrition does play a role, and it helps us, and it also heals us. And food patterns certainly do, but we can't always tell with symptoms alone. So let's talk about remission, right? Because I know that with IBD, and I know especially with myself, I don't know about you, Ashley, but when I was first diagnosed, I'm like, when am I going to get into remission? I'm taking these meds. Like, when is it going to be over with? Let's get the ball rolling, you know? So yeah, that also doesn't work either, right? Because that kind of messes with the anxiety and just like, okay, I'm done waiting around. So first and foremost, it's important that we are patient with ourselves and we take time with it, and that it's a healing process. So it can take time for the body to heal itself. And so with that being said, there are four types of, of remission. And so the first type of remission is clinical remission. And so clinical remission basically means when there is little to no symptoms present and patient feels well and not conflicting with quality of life. So maybe you're about to go to Disney World, with your family, and you're like, ooh, I'm going to go to Disney World. And yeah, for the most part, I felt pretty good. Like, I felt really good. Maybe I had a little cramping here and there, no big deal. Maybe I went, 4 or 5 times, but still overall, I felt pretty good. I was able to kind of keep up with the fam, my friends, and, whoever you went with, but overall you felt fine. So that's really clinical remission, right? Biochemical remission is when your doc takes some labs, and that can be in the form of a blood test. It could be a stool test to show any signs of inflammation. And so these labs can include C-reactive protein. It could be the sedimentation rate, calprotectin, or lactoferrin, which is found in the stool, that's in the feces. And so those are really important markers, and they're very sensitive markers to detect if there's any inflammation in the stool. And then we have endoscopic remission. And I'm laughing because I'm like, I want to get there.
Same.
Yeah, just got to be patient, right? Just kind of roll with the punches. So endoscopic remission means that there is no inflammation seen in the intestines during that scope. So doc goes in there, they're like, ooh, look at this nice large intestine. Ooh, it's nice and clean, and we don't see that much activity going on. So that's really what endoscopic remission looks like. And, the way that they look at this is through a colonoscopy, which looks at the whole thing, large intestine, and then the sigmoidoscopy, which looks more towards the left side. If you have a history of pancolitis, extensive colitis, if you see that it's throughout the entire colon, it's important that you really get a colonoscopy. I know sometimes doctors, at least this is what I've heard, they like to push more for the sigmoidoscopy, but I'd say just look at the whole thing too, because what's important to note is that UC usually starts as proctitis. That's usually how it starts, and then it kind of makes its way all around. So that doesn't happen to everybody, but it is also very common that can happen. And then the last type of remission is histologic remission, which they're still kind of researching and looking more into about histologic remission, because researchers are really looking at it thinking, okay, so histologic remission, let's figure out how we can really utilize this way of remission with medication so that our IBD patients can stay in remission a lot longer. And so histologic remission basically means that there's complete recovery of the colonic mucosa when it's looked under the microscope. So after the doc goes in, looks in through their scope, they take tissue, they take a sample, they take a biopsy, right? And then the pathologist, they look at that sample under a microscope. And if there's no activity of IBD, it does not mean that it went away or that it's cured, but that you're in histologic remission, meaning that there's no history found of it. But it's important to note that there's no cure for IBD, unfortunately, but hopefully we will get there. Yeah.
That was a really good breakdown, and I'm going to send out a recording. And if you go back and listen to this, save this slide, because this is important. This is something that I think you can revisit a lot, and it's important to understand those differences between symptoms and inflammation. And to answer your question, I didn't know the first time I was diagnosed with IBD. I didn't know what remission was, period. So if that's you and you're where I was, remission is basically, in a nutshell, when people refer to it, they're just talking about when the disease is not active. And there's all these different types of different levels, I guess, of when how inactive it is per se. So yeah, so I didn't know. And I think this is where a lot of people are with everything, is just they're just not told. They're not told what the remissions are and what the goals are. Often we're kind of just given a diagnosis and then kind of shuffled through. So
Yeah, no, I remember I had to sit down with my doctor and I was like, can you go over the different types of remission? Because I know there's like a few of them, but I really want to get your input on them. So yeah, but it's really good to know that there are different types of remission. And it also, it's important to remember too that we can be inflamed on the inside, but we have no symptoms on the outside, and vice versa. We can have all these symptoms. And then when the doctor goes inside, it's clean, right? And there's no inflammation. So the unpredictability of IBD, right?
yeah, and I've been both of those places. So I've been in a good spot where I'm controlling a lot of the symptoms with nutrition, and then my labs show a little bit of inflammation, and so I've definitely been there, and that's why we do need to check in on inflammatory markers. We need to do scopes because doing colonoscopies regularly, we can get a feel for what the inside actually looks for, which you can't look at through lab work. Unfortunately, we only get a part of the picture. So now we're going to go into the top IBD struggles and misconceptions. So these are things that you've probably already experienced if you've done a little digging at all in terms of nutrition, or maybe you might run into this in your next couple months. But the number one is that the internet is not the best place for individualized support. And the very hard part is that when you're diagnosed, you might ask for nutrition support and you might have been dismissed. And so you're left with where else to go, but where everybody goes, Google and the internet and forums, because those are the people that are actually trying to help you and that have the same thing that you do. But the downside to that is that you're often hearing people's experience instead of hearing evidence-based approaches, things with that have been studied. And so it's just important to zoom out a little bit and make sure that you're getting quality advice. And we try to provide a lot of resources for people on our blog, on Instagram, through these workshops, so that you can have access to just high quality, evidence-based nutrition support. So there are differences too between you and whoever else you're reading on the internet. There's differences in terms of your tolerance, your individual tolerance to things, your deficiencies. Somebody might be low in vitamin D or anemic, and that will actually impact. Deficiencies can actually impact your tolerance of different foods too. They can play a role in that. Inflammation can be different. The location of the inflammation, that's going to impact what works, whether or not you've had surgery. Surgeries can impact what you can tolerate too. So there's going to be different types of dietary adaptations that need to occur. So what your friend's disease looks like is going to be a little bit different than what yours looks like typically. Although there are things that overlap, it's just important not to compare your situation to someone else's. But that doesn't mean that we have to guess either. It's not like we're just guessing at what works. There is a lot of good evidence now more than ever in terms of what actually works for IBD, in terms of, every year there's a Crohn's and Colitis Congress that I go to, and there's different conferences where they go over newer research, and everything is pointing to the importance of using nutrition. That's more and more what we see in terms of helping your meds work better, in terms of increasing your chance of remission. So it's a good time to start bringing in some nutrition. The second top misconception is that there are no quick fixes. IBD can be unpredictable. It's very tempting, and I've been there too. When you're first diagnosed, you just want something to fix it. You really do. Like, it's a hard thing to accept when you have IBD, and there's a little bit of grieving that typically takes place for people. And so it just sounds so appealing to just take a probiotic or just take aloe and just be done with it. And it's not that simple. So we're often looking for that one thing, but it's important to remember there is no cure. And with IBD, because it's a multifaceted disease, meaning there are many different things that link to it, there are many different variables that can contribute. Because of that, treatment works the same way. There's going to be multiple ways that you can come at it to really help. And that's the best way to do it. We don't want to just look at supplementation or just look at restrictive diets. We want to look at the whole picture. We want to zoom out and have a plan that's more specific to you. So again, yeah, the internet's going to be full of that in terms of quick fixes and things that, just always remember that you're hearing a portion of someone's experience. So we're hearing, maybe it reduced symptoms, and absolutely believe that it could, but we're not looking at their inflammation. We're not looking at their disease state, and we're not doing their colonoscopy. So we don't actually know, we can't validate what people are sharing. We have to go with what we know about the disease itself in research, what nutrition approaches are effective. Those are the standards that we have to kind of go by. And just some tips around like how to really sort through all the information. So what I hear from a lot of people, especially those newly diagnosed, is they're like, I'm so confused. There's so many different conflicting things online. How do I know what's important? And how do I know what's important for me? So what can help you filter it out a lot is to look at, one, is the person who's telling me this, are they qualified to help me? Meaning, are they specialized in this area? Do they have education and experience to back that up? Am I speaking to someone that I can trust, that's reliable? And is there good evidence for using this? So if someone's giving you advice on something, they should be able to back up what they're saying. So if they're saying that a probiotic is effective for what you're struggling with, or with your symptoms, or for IBD, there's got to be evidence to support that. And they should be able to tell you that. Like if you're working with a practitioner, for example, they should be able to tell you what the evidence is in a way that you can understand. So that narrows down the field a lot in terms of information. So it's not just that everything contradicts itself. When you narrow it down with those criteria, that can really help you focus in on what's important for you. And it helps it feel less confusing. And number 3, conflicting information is often given at diagnosis. So this is really, I think, the hardest time of having IBD is when you're first diagnosed, because you're going through a grieving process of figuring out what this next chapter is going to look like. But 2, you're just not given a lot of support, a lot of answers, and most people aren't. And then if you search out nutrition, you're often told it doesn't matter, and it does. And you're often told just eat whatever doesn't hurt. But that's not really helpful, because if you're in a flare, literally everything hurts. So you need a little bit more customized guidance to really be helped. And then people are also told oftentimes, just don't have fiber, just go on a low fiber diet, or the FODMAP, or whatever, or SCD. But that's not helpful either, because it doesn't tell us the whole picture. It doesn't help with inflammation. Typically some of the diets out there can be more on the side of overly restrictive, which is also not where we want to be. So really the answer is, I think, if you can, working with a team that specializes in IBD, including your GI. So I didn't know this until years into my diagnosis, but not all GIs are specialists. So you can have a general gastroenterologist, and you can have a specialist that only sees IBD, or sees IBD and certain other diseases. But I think it's important to seek those out if you can, because it can make a really big difference in terms of their expertise and your access to things, your access to current research. If they're more specialized, they're going to be more knowledgeable in up to date in research. And then getting an IBD focused dietitian too can be helpful. There's lots of different ways that you can work with us or someone else. We work with people one-on-one. We also do group programs. You can come to the workshops. You can read the blog. There's many different ways you can get support, but I think getting that support is a really good first step.
Yeah, those are really good, Ashley, those misconceptions. I know that I could definitely relate to some of those. Yeah, so some of the actionable steps that you can take. So definitely there are some labs that you can request to your doctor because it's pretty common that your doctor will just order a CBC and a CMP. And so a CBC will give you kind of the basics, right? Like what's your white blood cell count, your hemoglobin, your hematocrit, your your comprehensive metabolic panel will just test, your GFR, your electrolytes, and other areas as well. But when we talk about labs for IBD and kind of understanding where we're at, we want to get a little more specific, and we definitely want to request specific labs to our doctor. And so these are some of the labs that we've kind of gathered that would be helpful for your doctor to see and for you to see, of course. So the first one, B12, also known as cobalamin. So as we had mentioned before with Crohn's, a lot of people, so remember that Crohn's can affect anywhere from the mouth to the anus, and it is common for Crohn's to occur in the ileum. And so we know that B12 and the ileum, that's one of the areas where B12 is absorbed. And so because of that, it's important to know what your levels are. Also, if you're vegetarian or you consume mostly a plant-based type of diet, it's also a good level to keep track of too. So that's something that we'd recommend. Vitamin D, very important because a large percentage of our IBD population is suboptimal or deficient in vitamin D. So that's really common. Definitely check your vitamin D levels. And most of the time, we have to supplement with vitamin D because it's not found in a lot of our foods and we get minimal amount. Well, depending where we're located too, if you're out in the sun, but most of the time we need that extra support. And from what I've seen, within our patients and just people in general, we tend to be low in vitamin D. The next one is folate, which I'm actually going to combine that with B6. So B6, B9, B12. So these vitamins tend to exist with anemia when anemia is present. And so that's why it's important that we look at these specific labs. Folate also is important to supplement when you're on certain medications. And so, for example, sulfasalazine or methotrexate, we know that folic acid is being supplemented. So that's an important marker to keep track of as well for those reasons. B6, also an important lab marker. We tend to be low in B6. And so remember that when we're inflamed, our body is hypermetabolic. And so what that means is our metabolism is running very quickly because we have a lot of inflammation going on. So we burn more energy. And so we utilize basically whatever whatever we have. So we burn through our energy. We burn through our vitamins, through our minerals, our antioxidants. And so it's important that we are testing these lab values for those reasons as well. Iron panel, especially for those where your ulcers are, in the colon. And so you know that if you're especially susceptible to bleeding, I would still recommend this for, my patients who aren't also bleeding, right? Because with inflammation, you can still be low with iron. You don't even have to be symptomatic. You can still be low. So, it's important to definitely test your iron panel. And so there's a difference between testing only iron versus an iron panel or iron studies. And so the difference is that with iron, you're just checking iron. With an iron panel, you go through the saturation, transferrin, the total iron binding capacity, and the unsaturated iron binding capacity. And so it's important that we look at all these measurements too, because your iron could technically be normal in your lab, but it may be possible that you're not actually utilizing it or you're not storing it properly. And so for those reasons, that can also shift into whether you're anemic. So you can be deficient, you can be iron deficient with or without anemia. And so to kind of understand what that means, we would have to look at the lab markers separately. So we want to see the whole picture. We don't want just a little snapshot. And the iron alone is giving us a snapshot, but the whole panel is giving us, everything. We can see the whole thing. The next one is calcium. So this is a very important marker. We definitely know that prednisone is a commonly prescribed medication, and we know that that can definitely affect our bones. And so, ideally, you want to look at calcium, ionized calcium. That's a little bit of a better marker. Or you want to look at DEXA scan, so a bone scan, especially if you've been on prednisone a little bit longer, and that's something that you want to talk to your doctor about. And so, just to kind of let you guys know that vitamin D and calcium, they work together. So calcium helps absorb vitamin D, so it enhances absorption. So yeah, or actually it's the other way around. And so vitamin D increases calcium absorption. And so zinc, that's another mineral that we want to check for. And so zinc tends to be a little bit lower, especially with diarrhea. So we tend to see lower levels with that. And the C-reactive protein, that is an inflammatory marker. So C-reactive protein is something important to look at. I have to say, though, that you can be in an inflammatory state and your C-reactive protein can still be normal, which is very odd. But that is possible. So I did read that in the literature, and I thought that was very interesting. And then fecal calprotectin. So fecal calprotectin is a very sensitive marker, basically neutrophils, which help fight against inflammation, and neutrophils can, that has a lot to do with the immune system. They tend to be found within the feces, and so they're not supposed to be there. But that's why fecal calprotectin is such a sensitive marker, because when you are inflamed, you see a higher level of fecal calprotectin. And ferritin. So, this is actually an important marker to look at in itself, because ferritin is that storage form of iron. And so, again, you could be producing iron, producing it, but you may not be storing it. And so if you're not storing it adequately, then you can have some symptoms, you can be fatigued. And there's a lot of, reasons why that, maybe you're not storing it. And so you need additional support for those reasons.
That's good. And with ferritin too, you can even see joint pain. You can see just being slower to heal. There's lots of kind of ways outside of just fatigue that you might notice it. And I wanted to add to kind of what Rebecca was saying, just some outside the box thoughts on some of these nutrients. In terms of why is it important that we supplement if we're low in vitamin D, or if we're low in iron or ferritin? It's important because, so for vitamin D, vitamin D is an important regulator of inflammation. So when we're low, we know that it correlates with severity of flares. We know that it correlates with development of IBD, the length of flares. So it's an important regulator, kind of like a light switch. So if we need it to kind of turn on and off inflammation, and it's not high enough, that can put a bit of a damper on us coming out of a flare. So that's an important one for flares. So if you are low, that would be a top priority in terms of improving your levels so that you can get to remission. And then folate. So all your B vitamins, including folate, are important for energy production, but folate in particular is also important for preventing your colon cells from becoming cancerous. So it plays an important role in that. So it is one we want to look at. And there's many other ways that it connects to. It's even the building block of a lot of neurotransmitters. So it can connect with mood and stuff like that too. So those are like your outside the box. We hear about vitamin D all the time with bones, but just to kind of connect the dots a little with IBD too, like it is an important one. All of them are. I think sometimes they're downplayed when you get your levels back, and but they're important. They're really important to your healing. And then in terms of nutrition, what's really important here? What are some actionable steps that you can take to start feeling better? So there was a study that came out in 2020 that looked at kind of a big picture overview. What's really important when it comes to IBD? What do we need to lessen, and what do we need to keep more of in the diet? And what they found, and this is consistent with other research on the gut microbiome and all your gut bacteria present, in terms of what we already knew. And the consistent thing was, one, we want to limit myric acid, which is like coconut oil, palm oil, dairy fats. So we want to keep those minimal. We also want to decrease or increase the intake of omega-3 fatty acids. So omega-3 fatty acids would be things found in fatty fish like salmon and halibut, herring, walnuts for vegans, and flax. We want to increase those because those are very gut bacteria friendly. And this connects on with your gut bacteria and what we know about that too. So, and then the other two were we want a diet that's lower in saturated fat. That's consistent with the last thing. Coconut oil tends to be higher in saturated fat. And then we want to decrease the intake of additives and preservatives. So some examples of that are polysorbate 80 and carrageenan, some emulsifiers, artificial sweeteners, titanium dioxide. You want to kind of minimize that. And I think there's one I'm missing, polysorbate 80, which I've actually seen in pretzels, by the way. So this isn't something that's just like obscure. I've actually seen it in Cinder's pretzels. So, and that's an easy thing that you can just swap, like just swap for a different pretzel that doesn't contain it. But yeah, so there's a number of different additives that you want to just keep in mind. Carboxymethylcellulose is the other one that I almost forgot. So that one I've seen in certain ice creams. I've seen it in some pizza doughs. It's carboxymethylcellulose is the full name. So just keep an eye out. It's typically really easy to find swaps for these things, or making them yourself can be a good alternative. We also know that we want to increase intake of fruits and vegetables. That might sound obvious, but it's not always easy for us to do with IBD. So basically, one thing that we do know, this is just a shortened version of how we help people. One thing that you can do to help with tolerance is making whatever you have smaller. So thinking of things like maybe you don't tolerate kale or spinach on their own, but maybe you can try it in a smoothie. In decreasing the size can actually do two things. One, it helps build tolerance. It helps you tolerate it better. And then two, it actually does increase the quality. So not necessarily the vitamins or minerals, but it can increase something called phenols. So they're the plant pigments that have the antioxidant, anti-inflammatory effect. They did a study actually recently in May, and they looked at mushrooms and broccoli and onion and carrots, and cutting them, shredding them, actually increased it by double and sometimes 5 to 7 folds the more that you break it down. So that works out great for us because that's typically how IBD people tolerate things better. The other thing that we know that's important with IBD is increasing fiber intake. And I know that's probably going to be a surprise for some people because that's not what you see online at all. You see the opposite. Everybody's afraid of fiber. But know that if you are afraid of fiber, know that not all fiber is the same. There are soluble fibers, there are insoluble fibers, there are resistant starches, and there's many different ways that you can have fiber that are tolerable, that don't make you feel bad. So if you've been told to not have fiber, just consider that bigger picture. So you may, there's certain scenarios where you may have to decrease fiber or decrease the type of fiber and switch to more solubles, like if you've had a surgery or you have narrowing or something like that. But typically it's with the goal of keeping fiber in longer term, because what we know about IBD is that it increases your chance of remission. So those that included fiber, there was a study that looked at people who used fiber versus people who don't. Those that included it were 40% less likely to have a flare. So it can make a pretty big difference in terms of really supporting you. The other way that we know that it connects in terms of gut bacteria is that it can help improve something called butyrate production. So your gut bacteria, especially the helpful ones, like Faecalibacterium prausnitzii. I don't know if I said that right. All of your really helpful gut bacteria, they like to produce something called butyrate. Butyrate is actually pretty cool. So it helps with repairing the digestive tract. It helps with inflammation reduction. It helps improve the gut lining. There's so many different ways that butyrate helps. And we want to increase that because that's really what's going to make the difference in terms of your diet helping you and helping with the treatment plan that you're on. And we also know that fiber can help, like I said, lower inflammatory markers in the long term. So we're not just talking short term here. We're not talking about having it one day and the next day you're out of a flare, but we're talking about, weeks and months of doing these types of things on a consistent basis can really improve your chance of remission. And going into a couple of things we can let go of. So Rebecca can start us off there.
Yeah. So what we can let go of, because we know that, when we talk about IBD, it's not just one aspect. We have to look at a lot of different areas. And so it's not just nutrition, right? It's not just seeing your GI doctor. There's a lot of other areas that we want to focus on. And some of it is understanding that, sometimes we have to let go a little bit and not just try to do the best that we can do to fight the waves. Like, you can't understand that you can't fight the waves, but that you can learn how to surf them, right? And so this was actually a really cool quote that Ashley found, and I really like it. So we can't fight it, right? But we can kind of go with it, right? And just kind of go with the flow of things. And so I think that's something really important to remember. So the first thing that we would like to let go of is just over analyzing symptoms. So thinking to yourself, ooh, I just felt something. What does this mean? Does this mean I'm going to get into this? Because I experienced this last time. And so just these overflow of thoughts. And I have to say that they're unnecessary thoughts because they can just trigger more nervousness, more anxiety is something that, is not going to serve you. And so being able to just kind of let go of that thought and maybe taking a couple steps back, taking some deep breaths and just reminding yourself, okay, maybe my body's just talking to me. Maybe, I did something that I didn't like. Maybe I went too hard on the bike earlier. Maybe I was stressed out because of an email that I got, right? So it could be anything. And remember that it's not always correlated with food, by the way, because that's something that we tend to blame first is the food. Um, and so when we overanalyze symptoms, remember the difference between irritation versus inflammation. So kind of what we were talking about earlier, that there is a difference. So just because you feel some sort of symptoms, it doesn't necessarily mean that you're inflamed. Trying to control IBD. So we know that IBD is so unpredictable, and we know that that unpredictability can be very stressful at times. And so remember, something that I like to tell myself, and I've also shared with, a lot of our patients and just in the community, I've shared that my husband also has IBD. He has Crohn's disease. And so he actually taught me this when I was diagnosed. He said to me, this too shall pass, this too shall pass. And so he told me this because he would tell himself that when he was, hospitalized and he had to get an NG tube in. And so, these are the things that, I would have to remind myself. And so I want to kind of share with you all that just kind of remind yourself that this too shall pass. This isn't forever. It's just, I like to call them little hiccups, they're hiccups, and we'll get over them. And we will definitely move forward from them. And the unnecessary worries. So stop a spiral with action steps because they can cause unnecessary stress. And so we definitely want to do the best we can to work on that. And just remember, something that I like to tell myself and also to our patients is that we always like to strive for better and not perfect, right? There's no such thing as 100% or perfection. So we just have to take it little by little, day by day. Yeah.
Yeah, I really like that. Like celebrating the wins, like however small they are. Sometimes they're small.
Oh gosh, but they make all the difference.
Yeah.
Yeah.
Especially if you're in a flare, like literally celebrate getting out of bed, going through it. The fact that you've made it through another day, just whatever you can find can be really helpful.
Yes.
Other things we can let go of. So for one, only focusing on nutrition. So just like Rebecca just said, nutrition isn't the only factor involved with flares. There are many different things. A lot of them are outside of our control. We can't eliminate, stress can be a contributing factor oftentimes for people, and we can't eliminate stress. In a lot of your life, there's a lot of uncontrollable life factors, especially in the last 2 years. where we didn't have a lot of control over whether or not we were stressed. All we had was our response to the stress. And I think that's the important take home point, is that you can't control stress, but you can control your response to it. You can control how much it detours you, whether or not you spiral, or how far down the spiral you go. So just remembering that, although nutrition is important, I mean, that's what our whole company focuses on. It's not the only thing that matters. You really do need to consider your life, your stress load, whatever is your contributor. And then two, we can let go of over restricting. So this is probably the thing you'll run into the most with IBD, is that everything you find online is all pretty much in the category of over restricting any sort of diet. A lot of the common diets for IBD, including SCD or IBD, AID, a lot of them, while they might be beneficial for some, they can be overly restrictive, with the same benefits as you would get from other type of dietary patterns that are not as stressful. So they have studied SCD compared to kind of like your standard Mediterranean diet, and they're the same, if not better, with an easier type of dietary approach. So keep in mind, it's the dietary patterns that matter, not being perfect on any specific diet. So keep that in mind too. Focus on what you can add. So always with IBD. So if you did a search right now, and I challenge you to, if you haven't already, maybe do it. What to eat with IBD? Everything that comes up is going to be what not to eat. And we want to change that narrative. We want people to focus on what you can add, because the more you focus on what you can add and add into your diet, add into your life that's supportive, naturally the things that are going to be maybe less helpful, that you're wanting to minimize, are going to be decreased anyways. And putting that focus on that really helps take the stress out of figuring out the dietary stuff. So focus on what you can add, not take away. And then in terms of what we want to reduce, just focus on reducing dietary patterns rather than eliminating foods altogether. So I mentioned dairy and coconut oil. A lot of foods that don't have dairy will have coconut oil or some kind of coconut fat. This doesn't mean that you have to never have anything coconut again. I would say start small, start with finding alternatives, start with reducing, start with one thing at a time. If you start something and start slow at your own pace, you're going to be better off than if you try to, do a 180 overnight. And then the last one, and I think this is the most important one, is that you don't have to do it alone. None of this, you should have to do it alone. And that's why I'm in business. That's really something that matters to me, is that I went through a lot of my flares and hard parts of IBD alone. And looking back, I don't want that for people. I want people to have community. I want people to have access to high quality nutrition. I want people to have support, because when I found that, it's really improved my life. It's improved a lot of the patients' lives that we work with. So just know that you don't have to do it alone. And there's lots of different ways that you can get support. It doesn't have to be one-on-one. It can be in a group setting. It doesn't even have to be in a group setting. There's many different places you can start. So you might be wondering, how do you do this? Like, how do you, even just the dietary slide that we looked at, how do we actually do that? How do we bring in fiber? How do we do that without triggering symptoms? So we help you really with the what to do part. So we help in answering that question, and we help you with the how part. We want to help you make that journey a little bit easier. And we just did a total redo of we have a course and group program called the Crohn's and Colitis Remission Blueprint. And it's really a roadmap. It's a roadmap through those initial stages of diagnosis and through the most important things that you need to know. So we talk about dietary things, and we don't tell you just what's important. We tell you the evidence behind it. We tell you supplement approaches. We talk about those. We talk about food-based approaches if you don't want to do supplements. We talk about not just those things, but also how to navigate this yourself. Like, how do you as a consumer look at everything as a whole and decide what's quality and what's quality advice for you? So how to kind of customize that. So it walks you through that. And then we also provide a meal plan and guide throughout. So not just meal plan, but we also help you with just using what you have in your kitchen and forming a meal. So we have an actual formula for how to help you through that part. And I want to share too, just an example of, this is one of many. We've had hundreds of people go through the program. And this is just an example of what is possible. So when Marie, I'm just going to call her Maria, I can't really use her real name, but she was with us. She went 8 to 10 times a day. She was skipping meals to avoid symptoms, which is really common. I'm sure you've done it. I've done it. She started the group program, and her symptoms during the first 3 months were reduced by 65%. So she went down slowly over time to 3 times a day. She had more energy because we stopped skipping meals. That's one reason. We also worked on bringing in quality nutrients. She felt more confident in her food choice. And I think that's an underestimated benefit to all of this, is how often do you feel stressed about when you go out to eat, for example, and you look at a menu, how often do you feel stressed by that? Or how often do you feel stressed with just knowing what to eat for dinner? I mean, that's a real life everyday stress that everybody has. But add on top of that, having IBD or having a food allergy, that's when the stress can really kick in. And we want you to feel less stressed there. We want to give you all the tools so that you don't have to feel that way, so that you can feel more confident in that. And I worked with Maria, and we worked one-on-one after. So I worked with her for about, I think, 6 to 8 months after. And we discovered she had low vitamin D. And so we corrected that. And we also saw her, we talked about fecal calprotectin earlier, Rebecca did, which measures inflammation specifically in the digestive tract. Hers went from 500 when she started in the very beginning 8 months ago down to a normal range. So this is both with, she had a medication that she was on from the start, but then she also added on top of that a really good nutrition plan. And so she was able to bring down inflammation significantly. And then by the end, her symptoms improved by 85%. So that's significant. So imagine, going down, being able to cut your bowel movements in half, or reduce bloating, or improve your energy. Even just small changes in that can make a huge difference in how you're feeling. So if you're interested in that, I'm going to, at the end of this, I will send the recording out, and I'll also send you a link to how you can get connected with us. We're happy to talk with you, or if you want to sign up, we can help you with that too. And I love to know, I want to get into questions, and I want to know, how can we support you? Do you have any questions on anything? And, what will you take away from today? And I know we have a lot of questions, so we'll start looking through those. Do you have anything you want to add to that, Rebecca?
No, I thought that was really, it was really great to just kind of hear, all the different, just, I guess, scenarios of just how, like, our patients have improved significantly with their symptoms. I see it all the time. And it's extremely rewarding. Just knowing that, they've decreased, let's say, their bowel movements, or, blood has decreased, or, we discover certain labs are low. So yeah, I mean, it's like I said, it's not just the food component, but it's also learning how to be an advocate for yourself, and speaking to your doctor, because that's really important. I mean, we go in there and we're kind of like, what do we do? What do we say? I mean, what do you do with things that you don't know? You don't know. So yeah, so I mean, I know every dietitian is different, but I know that, from, personally, what I do is I like to really help our patients to become more advocates for themselves. And so learn, the things to say, how to be prepared for your doctor's appointment. So, but yeah, I loved hearing that, patient Maria, she, she felt so much better, and that's huge. That's so rewarding. I love hearing that. Yeah.
Yeah. And you're so good at being ready for your doctor's appointments. We talked about that a lot. She's a pro at it. So I'll start with Ellie. So she says, where is this reporting going to be posted afterwards? So when you signed up I have your email address, so I'll be sending it out to all of the emails. But if you have any issues or don't get it for some reason, you can reach out to us and I'll put the email at the bottom in a second. Laura asks, is there a difference between palm oil and palm kernel oil?
Yeah, there definitely is.
Okay, tell me. I'm not sure I didn't know that.
Yeah, so there is a little bit of a difference. I think it depends on where the oil is being extracted from the actual fruit. So the okay, I hope I'm not forgetting this, but I think because I looked at this a long time ago, I think the kernel, so the kernel oil, I think that's more processed, it's definitely like refined than the palm oil. So the palm kernel, it's kind of like when you think of hydrogenated oils. So they are very saturated, and I think the kernel oil, the kernel, so I think it's coming from the seed. And I think it has a higher saturated content, which with IBD, we have just like what the IOIBD recommendations were when we looked at the nutrition slide. They recommend you lower your intake of saturated fat. So palm kernel oil is very saturated. And so is palm oil, but palm oil, I think, is more of like a natural type source. So it's a tropical, it comes from a tropical fruit. So it's kind of in the same realm as coconut oil. So still pretty saturated, but the palm kernel oil is, it's like even more so. It's like really processed. So yeah, it's just not something that we want to consume regularly.
Okay, that's perfect. Thank you. Because I was thinking there was like a difference between them. So yeah, thank you.
Yeah, yeah.
Okay, so Ellie asks, is there a fish oil supplement that you recommend? So there's a lot of different ways you can do fish. I think the most important criteria for fish oil is one, you want to know where it's sourced. Two, you want to know is it tested, third party tested, especially for contaminants. So you want to make sure that it's tested for things that can be found in fish oils, like phthalates and things like that. And the last thing is you want to have a good enough dose in the fish oil. So if you'll notice with fish oil, most on the market have, like 200 milligrams, something like that, like in the milligram range. With IBD, a lot of the research on it, you want it to be in the 2 to 3 gram range. So the research on having evidence for ulcerative colitis is 2 to 3 grams. So that being said, you probably don't want to take 10 of those 200 milligram tablets. That's going to be just ridiculous for anybody. So you want to look for a fish oil that has a good enough dose so that you're not taking that many. We do have a fish oil called Omega HP that I've formulated. So that's one that we have. There are other brands too that you can look at that use a higher dose, but that's what you're going to look for is those three criteria. You can also just have fish. If you do like fish, that's really the best way to get it. If you can get some in the diet, like with halibut or salmon or something like that. And then Laura also asked recommendations for the best food to start with increasing fiber. What do you think, Rebecca?
Yeah, so recommendations for the best foods to start with increasing fiber. So if you're just kind of starting out, I would definitely have it in an easier form. So blenderized, pureed, think very soft, cooked well. Especially when you're starting out with fiber, I would avoid having raw or, think of roughage, because when you think of it, like when you look at a head of like lettuce or like kale, you have to look at the fact that your digestive system is going to be breaking that down, right? And so it takes energy and time to break these foods down. So when you consume it in a smoothie or, just like what Ashley was saying, or let's say you like really massage the kale so it's super soft, I would recommend starting with that first and then kind of going low and slow with it. Go very slow with the fiber, just so that your body starts getting acclimated to it, because too much fiber can also cause diarrhea. And so, you, depending on what kind of fiber you're consuming, but yeah, recommendation would be to just do it in an easier form.
Yeah, that's good.
Does that help, Laura?
Yeah, it does. Thank you.
Yeah.
So Ellie asked, what kind of dairy alternative would you recommend for UC? I really like soy milk. You can also do, nut milks and stuff like that. You just want to be cautious with some of the emulsifiers and stuff that just want to look at the back for like care. What about you, Rebecca? Is there any that you really like?
Oh, there was actually this almond milk that I tried the other day, and it's just almonds.
Is it milk?
No, but is milk just almonds?
Milk is just almonds. Well, sometimes they'll put like salt or, just depends on the type. They have an unsweetened one that's just almonds. Yeah.
Oh, cool. Yeah, I haven't tried the milk yet. I think it starts with letter E, the one that I'm thinking of. I got it at like this small grocery store over here, and it's in a white carton, and I think there's like a little bit of green on it. I don't know if this resonates with anybody or if you like remember this brand, but it's just almonds, so that's pretty good. Or
Elmhurst? Someone
yes,
said
did someone say that?
Alexi says.
Oh, Alexi,
nice.
yeah, yes, it's Elmhurst. Thank you. Really good. I like that one. Or if I can't find that, I'll just get 365 Whole Foods unsweetened almond, and I'm fine with that too. Yeah.
Nice.
Yeah.
And Chelsea says, I'm glad oh, wait, we have one from Haley. Yeah. How often should you expect a request for lab levels to be rechecked if you know your baseline numbers from labs taken at your point of diagnosis? What do you think?
Well, okay. So just to be very honest with you guys, I bother my doctor a lot, and I try to get labs done as much as I can, just so I want to know. I'm anxious about that. So how often? So first off, it depends what lab you're actually testing for. So let's say, for instance, your vitamin D levels are low, and then you start supplementing. So you don't want to do it in 1 month, because you got to give it some time, right, for adjustments. So I would say maybe 3 to 4 months, probably looking more towards the 4 months, to see if there's any kind of change, any bump, and then you can kind of, modify the dosing of the supplement. What do you think, Ashley? What if it's like they're calprotectin, or what do you usually think about that?
I like to know what calprotectin's at. This is just from patient/practitioner. I like to know if my treatments are working. So I want to look at it every like 6 months to a year. That's just me personally. At least yearly, right? Because you want to check in and know, like, I think fecal calprotectin can be a little bit preventative in terms of even before your flare, you can start to detect inflammation levels coming up. So I think that's really helpful, because if you start noticing that before you're symptomatic, you can start interventions. Like maybe you can increase your meds with your doctor, or maybe you can bring in something different with your nutrition protocol. So that's one I like to run. If you've never done vitamin D and some of those, like any time would be a good time. And with iron, I would say yearly. If you've been low, more often than that. But you don't want to do it too often, because you do have to wait for levels to come up. Mm-hmm. And Chelsea says, I'm glad you said what you said about being patient with medications. I've been on a treatment plan for about a month, and I'm having symptoms, and I was getting worried. So I know it's probably not my medications aren't working. It's just that it takes time. I couldn't relate more to that. Really.
Me too,
yeah. It's
those
hard.
enemas, those enemas, they take time.
Yeah. To be transparent, like the enemas, the first 3 months were terrible. When I did rectal mesalamine enemas, terrible first 3 months, had to lay there for like 2 hours. But then after that, it started to get better. And now it just takes me like a minute to do it. And so
a minute? It takes you a minute?
Seriously, I'm done in a minute. I have to lay there for 30 minutes still, but
yeah,
just know that all of these things take time, even if they're working. It's not overnight. This is one of those things where that's a part of IBD. Like nothing is overnight.
Yeah. And everyone is so different too.
Yeah.
And their response to medications, you know, just like how Ashley's saying it takes her a minute. And I'm like, a minute? Because it still takes me like at least like 5 to 10 minutes.
But Rebecca, it took me 2 years to get there.
Okay. All right. That's fair.
That's a long time.
That's fair.
That's a long time.
Yeah. No, it is. It is. That's great. I'm happy for you, Ashley. That's awesome. Yeah. That's good. But yeah, no, we're doing the best we can do. So
yeah. So Chelsea is asking, is it better to have rice or quinoa, or is there another similar option that'd be a better choice? Is it a specific kind of rice that would be better? Do you want to say anything about that?
Honestly, I think it's a personal preference. I mean, for me, I like rice more than quinoa. Quinoa has never really agreed with me. I've tried it multiple times. I even tried quinoa in my chocolate, thinking that would be okay. And no. So it really just depends on your personal choice. Is there a specific kind of rice that would be better? I mean, honestly, I like brown rice just because it's a little bit more nutritious. We know there's a little bit more benefits in there. So that's cool. If you want a little bit of jasmine rice, that's okay too. But you want to think more of your complex carbs, which are going to really be your whole wheat type of carbs. So you want brown rice, red rice, wild rice is sometimes good too. But if you kind of mess around with a little bit of jasmine rice, there's nothing wrong with that either.
And Ali asked, I'm glad I got a probiotic question. Okay. I saw on one of y'all's IG posts about saying probiotics might not work in UC. Actually, it was Crohn's. So it's Crohn's that probiotics, there's only one strain that's effective with Crohn's. Was wondering what your opinion on Lactobacillus rhamnosus GG. I'm guessing you're meaning the GG strain in Culturelle. Yes, there is research on Culturelle in ulcerative colitis being effective. Now, what's interesting, and this is how it gets very individualized, in Crohn's, the same strain was not effective and caused more symptoms. So this is why you want to be specific to what your disease is and where it's located, all of that. In ulcerative colitis, there are a lot more strains. Ulcerative colitis is the genre of IBD where there's a lot of probiotic research and a lot of good strains. Microscopic colitis, there's maybe 2 or 3 that I know of with effectiveness. And with Crohn's, there's literally only one. I think, and even that one is more of like in the yeast category than bacteria. So keep that in mind. Yes, so ulcerative colitis, there's many, and we actually have a blog on that. So I'll link to that in the notes when I send all this out. And Ali asked, how often should we get a DEXA scan? How long does an increase in calcium intake take to show improvements on the DEXA? Okay, there we go. Do you have any thoughts on how, I mean, I guess not everybody needs a DEXA scan. I think it's going to depend on if you've been on prednisone, if you're aging and maybe you're more at risk for issues.
Yeah, I think that's a good conversation to have with your doctor, especially if they're prescribing you with the prednisone. Because in the IBD population, unfortunately, doctors, some doctors still prescribe low dose prednisone long term, and that can definitely affect your bone health. So I think that's a good conversation to talk to your doctor about, as far as when should you be testing for that, the length of time for that, and also even understanding if you are on prednisone for long term, what's the reasoning for that, and if there's another alternative. And then the other question was, could you repeat how accurate ionized calcium is? Yeah, so it is a little bit better because I know I have to maybe take a deeper dive into it, but I do know that ionized calcium is a better representation of levels rather than just calcium alone. Do you know why, Ashley? The why behind it? I would have to look deeper into it, but I do know that ionized is better, or even sometimes corrected calcium, because albumin is involved in that equation, in that formula. So it's better to, kind of look at other forms of calcium instead of just calcium alone. But I can look back into that and give you a more direct answer. Yeah.
Yeah, we can put that in the notes too.
Yes. Yeah, absolutely.
Chelsea says, absolutely. I've started prednisone and biologic infusions. And although they've had a slower stop, I feel optimistic. That's awesome. I'm happy for you.
Yeah.
And Laura says, I have to hop off. Yeah, no problem. Paige says, I've been on my medication for over a year. Through an infusion, I have 4 flares. I've had 4 flares while taking it, and I'm currently in a flare that is just as bad as when I was diagnosed with UC. My doctor said I might have antibodies against my medication now or have built up a tolerance. Is that possible? Yeah. We have a lot of patients who start working with us because of that, because they build up antibodies. And, there is hope for you. Like, it's not the end of the road. There's other biologics you can try. You can talk with your doctor about different medication options. And even bringing in some nutrition can also be helpful in terms of what you can do in the meantime.
Yeah.
Do you have anything you want to add to that?
Yeah, I mean, just like what Ashley was saying, that, it is possible to develop antibodies, and, it's great that we have a lot of resources, so remain hopeful and positive. And, I know it's easier said than done. And I can totally understand what you could be going through right now. But, I mean, there are other options. So, remember that, and remember too, that there's no such thing as failure, right? So there really isn't. And I know that, our doctors will sometimes bring up surgery, and remember that surgery is a treatment option too. So we have options, we have medications, and yeah, just remain hopeful and positive.
Yeah, and I just want to say I really appreciate everyone this is kind of incredible. We've had so many people that stayed on like the whole time. So thank you for being here. And I mean, we really appreciate it. And we're glad that we can be here and support you. And yeah, if there's anything else that we can support you with, feel free to reach out. We'll be sending out an email with everything too. So, but stay connected with us, and hopefully we'll get to talk to you all again.
Yeah, no, thank you guys so much. This was really cool. And, just also, yes, we're dietitians, but remember too that we're also patients. We also have IBD, and it's really nice that we're able to, create this community with each other. So thank you guys so much for being here with us.
All right. Take care, everyone.
All right, guys. Bye.